We have a good quorum here, I think, in person online. For those of you, we still have Corner Bakery, who I'd like to thank personally for motivating some of our fellows to come in person. So we'll get started. So I wanted to give an overview of this talk for two reasons. Well, three reasons. One, full disclosure, this was the talk I gave for Michigan Grand Rounds. So I figured, to bring some of the stuff I learned from putting together this talk over back to UCLA. But number two, I think as a tertiary referral center and all the other sites that our fellows and our faculty are involved with, and actually doing a review of the literature, it's actually because cardio-oncology, we're still sort of at this phase where we're trying to understand subclinical detection of cardiotoxicity. We're still trying to figure out who's vulnerable to cardiotoxicity. But we really haven't given a lot of exploration to the opposite of spectrum when basically they're really sick and they're about to die. And in this sense, obviously, there's a lot of interest in trying to phenotype and classify the various forms of cardiogenic shock. And I would argue within cardio-oncology that this is a paradigm that I think we need to embrace and look into because we frankly don't understand a lot of mechanisms. And obviously, it's a high mortality frontier. The word frontier is also a bit cliche, I think, in the world of cardiology because frankly, everything is volatile. But that also is an opportunity for many of you, HIT fellows residents, that you can engage, explore no matter what job or what environment you end up going into. And also, the other thing is, as our CCUs become more and more overfilled with people with chronic disease states, what do you think is going to be one of the major comorbidities in the unit in critical care setting on ICU? It's cancer. And in case you're just thinking that's my bias, I have numbers to back that up. So we'll talk about it. So, anyways, we'll get started here. You guys are welcome to time anytime. Here are my disclosures. I would say the more relevant one is PI for the ATRA trial, Bristol Myers Squibb, which has a data set for immune checkpoint hepatitis, and also some consulting features. So my objectives are to talk about four major things: the growing cardiovascular burden and increasing cancer survivorship population, and the relevance of cardio-oncology in the critical care ICU population. Let's talk about the epidemiologic cardiogenic shock and how cancer impacts outcomes. And then we're going to showcase some phenotypes of cardiogenic shock, or CS, unique to the cardio-oncology population, and how some of these mechanisms drive some of these unique factors and why they're really relevant to you. And finally, discuss some avenues of treatment strategies to classify, treat, and improve outcomes in this growing and vulnerable population. And something I tried to do this time around for talks, and I give Alexander Sherman full credit because he's the one who did this for our fellows, if I remember. I'm going to do all my citations. I just assigned a QR code, so if you're interested in it, you can take a picture of your smartphone and save it for you. I know we always look at these talks and slides and go, man, that's a great paper, I should look at it up. But this would be an obvious quick access. Extra step for your phone. So let's first start by structure my presentation. We'll talk about the growing burden of cancer in our CVD patient population. I'm going to talk about three major proposed phenotypes, going from the more familiar to the unfamiliar. ACS syndrome cardio-oncology patient, the valvular cardiomyopathy cardio-onc patient, which I'll tell you what that means in a moment, and the inflammatory myocarditis cardio-oncology patients and future avenues of next steps. So going back to the whole reason why is this important, right? Because like most things in life and in cardiology, we always have to talk about, is this just a niche rare thing, or is it something that all cardiologists should be aware of? Let's first look at the statistics of morbidity and mortality in the US. As of 2022, cancer still remains the second top cause of death in adults, both males and females. If you break it down by ethnicity, whites and females, it was second highest. And I'm just going to highlight, also showcase, identify Hispanic males and females. Interestingly, COVID is the second cause of death, and cancer was number two. Obviously, before COVID-19, the pandemic, cancer was number two. This probably implies some issues about disparities in access to care. But overall, as treatments continue to improve, cancer treatments, and I'm not going to go into detail because I've said this ad nauseum in their talks, we're going to see a much more chronically, cancer has become a much more chronically state. People are living longer, whether they were cured of cancer or whether they still have cancer. And I always reemphasize this to my cardiology colleagues because many of us still have this, stereotypical image of the stage 3, stage 4 cancer patient being sort of a hospice-based patient. And many patients are living many years on treatments that either consist of an IV monthly infusion or just a daily pill, kind of like statins or SGLT2 inhibitors. You can see here since the 1990s, we've seen an overall decrease in cancer, death rates. A lot of people, there's a lot of fussing about FASE. Obviously some things like smoking have also contributed to better public policies regarding that. But also at the same time, interestingly, cancer screenings tend to be still controversial because there's yet to be talked about mammograms. And, most breast oncologists will agree that mammograms are actually not cancer. But most people can uniformly agree that since the 1990s, treatments have improved and more treatments available to improve prolonged cancer survival. If you also divide it by sex as well, overall things have gone down. So what are they going to die from? I think we all know that as cardiologists, because of the CVD mortality and some of the stuff they would pick up from the treatments and indirectly, this is going to be a population that's going to be more and more of the, population, not just mine. And as of the next decade, we estimate again over 20 million US cancer survivors alive with a diagnosis of prior history of cancer treatments. So this is much more than the disease states that we are studying. So this is a growing population. Not all of them are necessarily going to have CVD, but if you already look at the top two here, what do you got? You got prostate, you got breast cancer. We already know breast cancer patients, you survive more than 10 years. So, for prostate cancer, we know that the interval is look at the, the RX study here from our colleagues at Conference. Oh, really? Is the microphone? Okay. Let me just see if I can turn on my. Here. Hopefully, there's not much of a. Is there an echo there? Can anyone say if there's an echo in the virtual audience?
It's much better now.
Okay, I'm going to continue. If there's anything else, someone say in the chat.
Better.
Better? Okay. Let me know if there's any issues here. So, study looking at our study, which is one of the biggest, ASCVD registries we have. Our colleagues in Hopkins cross-linked these patients with multiple cancer registries. And they even found out that even if you count for traditional risk factors such as smoking, diabetes, obesity, lifestyle practices, you would not, even if you put into all that account, there was still a higher, statistically significant higher risk for CVD and heart failure in the cancer population, whether it is related to the treatments or the indirect and direct biological effects of the cancer. And you can see here varying degrees of associations of types of cancers. And I've seen this personally, that definitely, especially with high-risk lung cancer and hematologic cancers, tend to be definitely the more high-risk part of our patients that we see here. Obviously, there are some issues with survivors. Lung cancer, unfortunately, has a horrible life survival. It still does, even with immunotherapy. But even then, there's still a lot of, I think, room for us to change this field to be more preventative and finding out how aggressively we can lower these patients' cardiovascular event rates and risk profiles. And going again to bring into really a diagram that I feel really exemplifies, really defines what cardio-oncology is all about, is the biological underpinnings of what our field is about. So really, again, it's looking at three major factors, right? The cardiovascular risk factor and profile of the patient with a new diagnosis of cancer, what the biology of disease itself will do to the patient and potentially affect their long-term ASCVD risk, and therapies they either will get or have gotten in the past. And this Venn diagram basically shifts for every single different individual and every single individual cancer and stage and type of treatments they will get. The one things we watch out for are both two kinds of toxicity, acutely during treatments, and if you can't stop that or control it, obviously that can affect our access to life-saving or life-prolonging therapies, or chronic toxicities, which can affect survival and morbidity and quality of life.
Now, moving over to cardiogenic shock. I think we all know this paradigm very well at UCLA, right? And, and I think we've seen, especially in our CCU and our consult services now, varying degrees of, peripheral perfusion, the warm, cold, dry, wet paradigm. And it's interesting to say because I think cardio-oncology has had some phenotypes which I frankly think really defy or really, mess with our expectations of how these patients are frankly even able to survive and maintain, any kind of perfusion whatsoever. And this is why I think we need to really start closely studying these really, I would say advanced cardiotoxicity-based patients. Some of you know the sky shock paradigm or like a pyramid that came out 3 years ago, essentially looking at patients who are at risk and then essentially deteriorating, and then sort of classic C shock. We obviously get a lot of requests for transfers for C, D. E is someone who's actively coding, and those are obviously the ones that have really, really, poor outcomes. But even then, despite our, our advancements in STEMI, systems of care, our interventional procedures, and the degree of MCS we have available, I'll show statistics and general mortality still remains obviously very, very high. But also the question is, where do the cancer patients fit in this paradigm? How aggressive should we be in trying to control for these, these patients? So if you look across the spectrum of various studies, if you look at really, the extremis, the E extremis, the red bars here, it's not surprising, right? These mortalities, 3-day mortalities are really above in the high 60s all the way up to like 100%, especially out of hospital cardiac arrests. But also if you look at the stage C or D, right, that's the patient's re-C, that's the patient's J sometimes gets in the cath lab. You can still see here overall just mortality is, exceptionally high. It's almost like a flip of the coin. And yet we still go, full court press with these patients. Another way to present data, you go by age, same thing, where you are, due to morbidity, other sort of biological things that put you at higher risk, your mortality obviously escalates with each stage and each, increment in the age group as well, too. So moving over to, again, the cancer population. So what's the incidence of now cancer patients in the critical care sort of setting now that are being managed? And this is a study that came from a sepsis study over in Europe with a registry. And this was about patients who they compared about 400 patients with cancer versus those who did not have cancer, and looked at sort of their use of, their monitoring and their outcomes. And you can see here in general, in terms of cumulative survival, not surprisingly, and some of you have known this from your moonlighting on J service, hematologic patients certainly have the worst, outcomes. But solid and no cancer, interestingly, sort of have somewhat similar sort of survival curves. What I also found very fascinating about this, again, this is a European study. This doesn't necessarily apply to US. But look how much, up to 10% of patients were still having swans in place for dynamic management in the cancer population. That's even, I think, arguably more than us, And this is, again, a snapshot of how the Europeans also, manage their critical care patients. So you can see here that there is a degree of either aggressive approaches to management or, patients with chronic disease states that I think that they're just basically doing whatever they can. And essentially that, this is a growing population that, will slip over to our CCUs if not already. And in fact, this is already a study that was done 3 years ago. This was looking at Brigham's CTICU, okay? And they looked at the demographic, and about 13% of patients over the time period, about 2,000 patients had a history of active cancer. So it wasn't prior cancer, it's active cancer. And not surprisingly, a good high incidence of cardiovascular disease. And interestingly, what was the major reason they were in the unit for? A quarter of which were shock or hypotension. So this study didn't really specifically look at how many cancer patients, were presenting with what. But just goes to show that if you look at the olden days of 20, 30 years ago, most of the CCU were either post-MI or cardiac arrest. And now it's more and more shock, heart failure, hypotension-based illnesses. So I think, again, and we're seeing this already in CCU, you were having a lot of overlapping disease states, which is honestly why the critical care movement within cardiology, I think, has a lot of good points to say, well, we need to have specialists who are more focused on not just being able to manage cardiovascular issues, but also the other critical care aspects of pulmonary ventilation and other, non-cardiac issues, because critical care is becoming more and more mixed with these patients with 2 disease states. So with that, I will switch over first to our first ACS patient. I'm so happy Jay Patel is here, so he can tell us what he would do in these cases. So first of all, 66-year-old male with advanced lung cancer, post-cancer treatment, carbo, paclitaxel, nivo. Interesting, already had a known non-ischemic cardiomyopathy with an outside angiogram that was negative. Came to UCLA for a second opinion regarding his lung cancer. And interestingly, like many cardio-oncology patients, they come into clinic just really, really looking bad and sick. Came into blood pressure with a blood pressure of 66/48, troponin I of 84, BNP 1400, lactate of 34. CCG is here. You can see Q waves and ST elevations. We're not sure of the acuity of this with ventricular bigeminy. Essentially, obviously, with all these markers, obviously concern for active, if not ongoing, ACS and obviously evidence of shock. So this is his initial angiography, the REO view here. You can see an occlusion of the mid-LAD, or it seems to just taper off really rapidly. Also, same thing, just like really thinned out, essentially a vessel which kind of terminates her in the mid-segment. If you can see closely here, interestingly, you can also see there's some faint multiple collaterals going to something outside the heart too. So that's a bit interesting as well. So the right heart cath is done at the same time because the patient's obviously in shock. I know this is kind of actually, let me minimize this thing here. So you could see the patient's obviously very decompensated, blood pressure 45, cardiac index of 2.1, cardiac CPO 0.64, and an index PAPI of 1.1. IVUS, based on this CT look, you can see in the 4 or 5 o'clock area some echogenicity outside the vessel here. This is after post-dilatation for the first post-inflation. So with that in mind here, and you said, this lung cancer is obviously quite significant. So then the next question then is, what's the next step? So do you undergo PCI with no support, balloon pump PCI, impella PCI, ECMO PCI, MCS only, no PCI, or palliative? So Jay, first day at Henry Mayo in this case.
What was he's answered. What was the gap?
Well, we know before it was 25 to 30% already. So in pre-existing cardiomyopathy.
Yeah, it's. I mean, if he doesn't have any contraindication, support. This is a big vessel territory. To show up with so you don't want to sort of support. And it looks like based on the IVUS here, I think I'm pretty sure I did this case, but yeah, it's like external compression, likely of that vessel as well. But intervening, if it gets shut down, if you think compression is significant, you would try to intervene. But I would definitely do support for sure.
So if you had your choice, what would you want?
Probably these days we're trying to get away with as much support as we can. So impella, I also know that Marcy did a case. I think I did this case with Marcy. When Marcy did a case with DJ, that was like insane case where we did just fine with the two.
Well, I think the other thing too that we have to be cautious about, though, ECMO is also the nicest thing because it does bypass core physiology. But the fact is, lung cancer is once this bridge, right? We don't know. And a lot of people are like, well, what are the scores of care? But unfortunately, sadly, lung cancer patients who come here with still an intention to do full court press, and it's very difficult to have these discussions when someone is sick. So, so I think what you did was very reasonable. And I think, she's obviously in a stage D, kind of close to E sort of stage. So went on impella support here. And underwent PCI with a 2.5 designed sky point, drug balloon stent, post dilate to 3 millimeters approximately, with good flow, or relatively good flow afterwards, with support afterwards. So, sorry, going back to this. So, some unique concerns with this patient. What is the ideal revasc strategy in this patient with advanced lung malignancy should even be done, given how he's presenting? How much of their cancer biology is contributing to the hemodynamic instability? Also, the big question we always have, what's the risk of bleeding with DAPT, right? And how long can we be on it, in case he does have bleeding or he needs surgery or something else, right? Or he gets thrombocytopenic. So I think that's always the question I think we always get with the ACS active cancer patient. And the other thing too is that there may be some people in the audience saying, well, why do anything? This guy's stage 4 lung cancer, or at least he looks his advanced stage, what's the point? Well, if you look at those sky shock statistics in general, I would like to propose the question, why do we do anything if we know these mortality statistics are that bad, right? So if there's a goal to potentially treat, or at least prolong life with treatments, you can make an argument to say that it's still important to try to do everything you can, from a cardiovascular standpoint to optimize him if there are still certain options from that standpoint. And we're caught all the time, unfortunately, in this very uncomfortable situation where they have a cardiac event. We're not sure what their cancer prognosis is, but there's always usually something on the horizon if you talk to our cancer colleagues. So you kind of have to do something from that standpoint. So, and why does this happen? So this is a nice review written by Orly Leva, who's an NYU fellow who I'm working with as well. This nice JACC Cardio-Oncology review showing that obviously, platelet activation and aggregation are very distorted and probably enhanced with factors related to tumor progression and aggregation. And we're seeing outcomes data supporting this. And also they can affect, levels of LDL oxidation and increased inflammation, which can lead to prolonged or accelerated atherosclerosis and also high rates of thrombosis through a variety of mechanisms. And I think that this is not something we should just assume cancer does as a whole. Certainly some malignancies do it better than others or do it worse. And the question is, what are the cancers that are more likely to do this? And essentially, this has been looked at on a big scale. And a study from Dr. Navi and colleagues at Cornell looked at a Medicare SEER database where they saw that essentially that, the higher your stage was of cancer, the higher rate of arterial thromboembolic events were if you are counting MI, ischemic stroke. And unfortunately, your risk of thrombotic embolism was usually the highest at diagnosis. And essentially the most high-risk patients in general were lung cancer. And also the higher bleeding risks were GI, not surprisingly, and lung cancer as well. If you also look at the cancer, the impact of cancer diagnosis and trends of cardiovascular hospitalization, you can see here overall, and again, I think this speaks to the fact that cancer is becoming more of a chronic disease state. Cardiovascular-related issues in this study by Dr. Mamas and colleagues show that that the rates of hospitalization continue to climb. And if you look at, in general, what the reasons for these are for is, above all else, heart failure. And what do we get in the CCU now? Based on that data I just showed you, a lot of heart failure, right? And then AMIs and all these other things, P, not surprisingly, is still there. But also if you look at the types of cancers, again, hematologic, still the most high risk, and also lung is the second in terms of in this European analysis. PCI rates also are going up, and lung cancer, again, is associated with the highest in-hospital mortality. This is looking at the national inpatient sample, and also any complication related to this, the procedure as well, and bleeding tends to be higher. And not surprisingly, colon cancer is also high up there too. But looking at prostate and breast cancer, you can see here it's actually, not that much different compared to non-cancer controls. And that makes sense. And most of the time, I think we tend to be pretty aggressive because prostate and breast tend to be sort of chronic, more slow progressing cancers. But if you look at a propensity score matching analysis of PCI on in-house outcomes in active cancer patients with STEMI, look at lung. If you don't do PCI, again, this is selection bias, it's retrospective. You can see here the events of MACE, all-cause mortality and major bleeding are just like exponentially much higher compared to undergoes who goes all the other cancer groups as well as PCI. So, again, this is something just to kind of bring up the conversation that I think we're going to be seeing a higher concentration of active cancer patients in the cardiovascular care realm, especially in the ICU unit. And unfortunately, like this patient was intubated, extubated, but reintubated after they tried to take out his impella. And on Bumex infusions for volume overload, Milrinone could not be weaned off. Eventually, he decided to pursue comfort care cancer, was saying, given how sick he is, he's not a candidate for anything. Expired, 17, hospital day 17. So I think, unfortunately, as time goes along, again, a lot of these treatments will keep these patients, with either stable disease, but they're going to get more cardiovascular events. And I think that's something that we have to still study and understand. And some of them, a minority of them will present, obviously like an ACS shock. And we still need to know who should we be aggressive with, how should we intervene, and what's the best, type of MCS support we should provide these patients based on prognosis. And I think that requires a lot of multidisciplinary discussion. So phenotype 2, the valvular cardiomyopathy cardio-oncology patient. So I feel bad for Marcy because she deals with all this stuff I sent her. So 67-year-old female, history of left breast angiosarcoma 36 years prior. So seeing someone like her is obviously a rare person because most of these women did not survive this. Obviously got anthracyclines. Through chart lowered urban legend, she's got about 120 grays of chest radiation. So that's like 1960s style. But you can see what it was like, what it did to her rib cage, because essentially she effectively had no sternum because her whole sternum was just irradiated necrotic. And she also required multiple chest reconstructions. Because she had no rib cage, basically you could see her heart impulse coming through her skin grafts. but doing well otherwise, except for having some dyspnea, orthopnea, and abdominal distension and weight loss for the past year. You see on this TTE here, severe open tricuspid regurgitation. She gets admitted for drainage of a pleural biopsy, a fusion of biopsy, because of, So essentially, because there was concern for malignancy on chest imaging, which thankfully ended up becoming negative. Came back to clinic less than a week later, one of the sickest people I ever saw in my clinic, SVT in the 180s, couldn't really get a blood pressure on her, clinically in cold clam and shock and urgently readmitted. Went to the OR actually, with sternal exploration debridement, no obvious source found, BNP 724, so it's negative. So what's the next best step, right? Since we're a little bit short on time, because there was no thought that she had active cancer, she's a cancer survivor, and it really wasn't sure, you have a woman who now has had chemoradiation with unclear overall, you definitely have a valvulopathy, but you don't know how much of cardiomyopathy you have, right? In your differential, there might be the concern for constriction, restrictive cardiomyopathy. So what is the best mechanical support available to bypass all these things? Ends up being ECMO, right? So she got a right heart cath and ECMO. And while intubated and on the ECMO, we can see here, and this is the pre-triluminate. This is before, any TR or TV was, actively done or investigated. And you can see the CVP was known to be 17. And this is some of our views in transgastric view, just kind of like thinking tricuspid valve leaflets and functional TR. And EROA 3D of over 0.9 centimeters squared. You can see here on 3D with some of our older machines here. Basically just sort of functional due to malcoaptation on ECMO support. However, before, when we got a TT on her before she got sick, there's something else that made things more complicated. Look at the intermittent ventricular septal shift, and look at how every time she breathes in, you can see how essentially the tricuspid leaflets kind of go in and out, in and out. You also have expiratory diastolic hepatic flow reversal, and also a nice triangular jet, dense jet across the tricuspid valve, signifying severe TR. So the other question then is, does she also have potential concomitant constriction, which is also of note very challenging to differentiate when you have active severe TR. So you have a few multiple clinical concerns. We think the TR probably is related to resumed from radiation, but could have also been exacerbated by concomitant pericardial constriction. Is there underlying restrictive cardiomyopathy? And there's also radiation CAD, she's never had an angiogram, right? And then her infectious workup thankfully was negative. She can't get any surgical or transplant options because she doesn't have a chest. So she doesn't technically have any anatomic sternum to go into. So therefore, we discussed, could this possibly be a candidate for a TEER MitraClip, TriClip implantation? And another big question that no one had the answer to is, what's the feasibility and durability of TEER and radiation valvulopathy? Does anyone have an answer to that? I don't know. And even now, we just still don't have that answer, right? So with that in mind, and this is, hopefully we're gonna get this accepted by Circ Heart Failure and Katie Truong, for some of you who know, who is now gonna be a fellow at UW next year. She's now doing a cardiac intensive this year. We have this decision branch point of what to do. Should we attempt a TEER on ECMO support, or try to wean her off and try to get her on diuretics, and then attempt TEER if she fails, right? So what are the pros and cons of all these things? So what would TEER on the right side do? Well, presumably, if successful, assuming it's successful, it might result in increased right to left flow, but also may increase your RV and RV afterload, and increase your LV preload. The problem is she's on ECMO right now, so her true hemodynamics, unfortunately, might be masked because she's unloaded because of the VA circuit. If you have concomitant constrictive or restrictive physiology present, what if the LV couldn't tolerate the sudden right to left flow, right? What if the RV couldn't tolerate the RV afterload that we induced by giving her a clip, right? And if she essentially gets worse than LV plus minus RV failure, we may not be able to get her off ECMO. We don't have a bridge. We don't have a destination target, right? So, but the benefits essentially is that essentially if we were successful and she didn't have these problems, then we could get her off ECMO sooner. Now, if we try to get her off ECMO, what are the risks? Well, being on ECMO longer, you're more susceptible to problems, like bleeding issues, vascular issues, and worsening right heart failure, venous congestion, AKIF, inotropic support. But if you were able to get her off, but if we were able to be successful, we could treat conservatively. And if we were to get her off ECMO support and she failed, same problematic issues apply. And where do we stop? What procedural, parts of the procedure do we say, we got to stop doing this, we can't do this anymore? So there was a lot of, kind of discussions. And we were literally having these discussions every day in the ICU, because we just didn't know what was going to happen to her. So finally, however, because of a lot of the unknown effects of, TIR, which we didn't know much about at the time, we decided to try to wean her off ECMO support first and see how she would fly on diuretics. And thankfully, she was able to get off ECMO by hospital day 20, right? So we started on diuretics, but unfortunately, she started to, unfortunately, her RV and her kidneys started to fail again, despite this, compared to her prior episodes. So therefore, the decision was we decided to go for TIR tricuspid valve, the valve. I like hemodynamics, and this was a nice little hemodynamic superimposed tracings that we did together just to see this. It's a really nice illustration of, severe tricuspid regurgitation. You can see here on the orange colored scale here, a C wave, not so much the V wave. Sorry, it's an S wave, I apologize. Because of the rapid upstroke, because you have essentially no functional barrier. So the V wave basically gets moved up and it almost equalizes with the RV systolic pressure here. And you see the steep Y descent here from rapid filling of the atrium and emptying as a result. And this just shows that there's really no effective barrier. And the mean pressures are obviously high. So, with guidance with Abbott, we did, 2 clips in the posterior septal leaflet area here. And again, here's some other shots. We basically caused an effective bicuspidization of the tricuspid valve. You can see here the TE guidance and a right heart cath. Because this was a very delicate case, we begged Marcy to do a right heart cath pre and post. And you can see here essentially the interesting thing that happened that we did not expect to happen in a otherwise normal heart. It's like the RA pressures went up. The mean RA pressures went up to about the mid-20s. But also, if you pay attention closely, the V wave starts to normalize now because you've effectively created a nice barrier here, of closing the tricuspid regurgitation here. But the RA pressures should overall presumably get better unless you cause severe tricuspid stenosis, and we were pretty sure we didn't do that. And also the RVDP with the improvement of RV afterload as well as improved right to left flow, the RVDP also increased to 26. So if you look at all these hemodynamics side by side, if you look at the end diastolic pressures, they almost all equalize to us. When it said that the RA pressures, interestingly, also paradoxically went up. Also, the LVDP also went up. Interestingly, the Cardiogenics didn't change very much. So this to us, convinced us that she probably had also concomitant constrictive physiology on top of this because she's now equalized from a diastolic standpoint. And this is the echocardiographic result here. You see our RV function still looked pretty good with mild to moderate residual TR. So you're like, well, the Cardiogenics didn't get much better. Did she actually clinically get better? And let's do a quick sort of, deviation about radiation valvulopathy and cardiomyopathy. So that's why I called this case valvular cardiomyopathy, because it's not just the valves. The whole heart, to a certain degree, is affected by these patients. So the Hodgkin's lymphoma cohort is probably the closest we can really extrapolate the data for this patient. But you can see here that in the early data, even at 40 years, the incidence of a cardiovascular event rate was 50%, meaning that half these patients were likely to get either a heart attack, valve issues, or heart failure, or a combination of all three. And this is a Dutch cohort where all the medical records are socialized and available, so it's just like the entire population of Hodgkin's. And again, across the board, your risk of CHD, valvular heart disease, heart failure, all go up. So that's my personal opinion that anybody who's a Hodgkin's survivor before like the 21st century who ever received chemoradiation should probably see a cardiologist at some point. Now, how do structural interventions affect those in cancer? And that's always a big question. We get that a lot also in our TAVR program. And you can see here that essentially that in this TAVR registry, that overall, in terms of survival probability, not surprisingly, cancer patients fared worse. But also, if you looked at stage 3, 4 versus stage 1 to 2, if you separate out these survival curves by stage, the earlier stages actually did not have much more difference, but certainly there was much more bleeding, not surprisingly. But also the later stage cancers also had worse outcomes. But at the same time, it is worth noting at the end of the year, at each 1-year endpoint of this registry, the ones who survived TAVR, 88% of them were considered to be in remission or partial remission. So we always get saddled with this very, for new cancer diagnoses, we always get this, this request from oncology, can you do the TAVR to stabilize a patient for cancer therapy? And we can't do it with a projected prognosis of less than a year. So we always go, well, what's the prognosis? And what's their answer? Well, we don't know until we start treatment. So we always get put in this cycle, right? And I think on a systematic level, we probably need to be much more analytical about this and much more. But in general, this is something we get all the time. By the same time, if they say he could survive more than a year, he or she can survive more than a year on therapy, then we probably ideally do what we can. There's not a lot of data on TIR. This most recent look at the TriNext Health Network here by some of my colleagues looked at TIR effects and survival. And again, if you look at hematologic malignancy was really over a quarter of these patients with melanoma and GU cancers. In general, survival outcomes were about the same compared to those without. So again, probably big survival bias, right? You're not going to get someone who's end stage, like really dying of stage 4 metastatic cancer. But again, it also shows for the right population, there's probably the outcomes are probably pretty similar. And we know at least, in the mitral valve space, the periprocedural mortality rates are next to nothing. And obviously hot off the press, some of you were at ACC, you probably saw this being presented. The Tri-Illuminate, which this patient probably would have qualified for, but we weren't a site, essentially looked at the outcomes of medical therapy versus using the Abbott, MitraClip in the tricuspid valve position. I think in general it's interesting because there's still a lot of controversy surrounding what this trial meant. In terms of really the only statistically significant benefit was an improvement in KCCQ quality of life scores, which obviously some people might interpret to say, well, that doesn't mean anything when someone knows they got the procedure or not. That might bias their whole sense of how they feel. And even more so, obviously there's 6-minute walk tests didn't improve. Okay, so that's not to say we shouldn't keep investigating this space, but I think there's certainly the trials that are being designed in the future, ongoing, should obviously be much more rigorously defined to see this. But they did see an improvement of the more TR they got under control, the better they felt by KCCQ. But again, you also know what you had done, so you're biased to kind of how effective of an intervention you had. So. But what about this? Again, like I said, I hate to be anecdotal about it, but again, this is someone who obviously failed medical therapy, and we had nothing else to offer. But she was discharged on hospital day 32, improved in New York Heart Class 2. She's on stable, actually decreasing doses of Bumex. She was able to attend her granddaughter's bat mitzvah 2 months post-discharge. Sternal wound actually healed last year. She has not been admitted for heart failure for 5 years. This happened over half a decade ago, by the way, in this case. And I still see her in clinic. She's one of my favorite cardio-oncology patients. So again, I think this is a space that also, can defy what we think of, what we can do for patients, but also this was also not just, I think this was not just, just 1 or 2 people. This was literally, 6 different services talking every day about what we could, what would be the right thing to do for her. And I actually attribute it because of this, not because of, statistics or cardio-oncology, the specialization. Just a lot of smart people getting together just trying to figure out the best strategy for her. But I think again we need much more data on this older surviving population with valve disease. And finally, phenotype 3, the inflammatory myocarditis patient. So 68-year-old female with a BRAF positive colorectal cancer, Xelox, Nivo, first treatment 5 months prior. Presenting with 3 weeks of palpitations, dizzy, blurry vision, presented to cardiology clinic with this ECG right. So I think most people who saw this 12 this would probably be a oh shit moment, right? Essentially, this is, you show like any EP doc this, you're going to get like 4 different interpretations. I think the best we can offer this is alternating ventricular fascicular rhythm. You can see VA conduction here with retrograde PD waves in all of them. With diffuse SC elevations, either there's a huge myocardial injury current or pericarditis, essentially. Regardless, next step, 911, sent to Santa Monica, UCLA, code STEMI activated, angiogram negative for CAD, EF of 38%, MRI initially negative for LGE. She was diagnosed with myocarditis and discharged. These were her initial labs on presentation here. So I want to bring your attention to some of these biomarkers here. BNP 173, troponin I of 30. AST/LT is obviously extremely high, more than 10 times upper limit of normal. And lactate was not done on the first admission, total CK of 6,300. Okay. So, She gets sent home on a life vest and some GDMT, comes back to RED 9 days later with worsening weakness, nausea, still in slow VT. Blood pressure, again, walked in, the blood pressure is 60/40, and started on dopamine. These are her readmission labs about a week later. BMP that's gone up 10 times, troponin I still elevated, AST-LT still elevated, now renal failure, and lactate interestingly only 24. So what's the next best step? I'm not known for my test writing skills, but right heart cath balloon pump, right heart cath Impella, I go steroids, right heart cath ECMO, right heart cath ionotrope only, or powder. Michael, this is for you. This woman showed up, and this is exactly what happened. CCU fellow called me, and she had already put in their diagnosis in the day. What's the next best step you would do?
Well, I think for her, it strikes me as like an investigative approach. So, you know, I think right off the bat, she seems like she's heading down towards MCS. And I think between a balloon pump and Impella, I'd probably lean more towards an Impella. You know, I also think like, you know, we could take a look at how she's doing with dopamine running and see how her numbers look, and see if she might be able to apply with anecdotes hopefully as well.
What do you think she has?
Oh,
it's okay if you're not sure.
Oh,
because
she
has
has
other
it.
services
Yeah.
did not believe what she had either.
I
I really had to fight with oncology because they did not want her on certain treatments.
with their history of checkpoint inhibitors.
You already have the benefit of having a negative path, so that was what we were about on the last submission, right? So what is your first step when you suspect someone who is really sick with the check over the diabetes?
Probably, so I don't know, my guess would be steroids.
Steroids, right. Even on the way up, you start pulsing. This woman's already been sick for at least a week, right? And we'll talk about some other really high risk features. That's why I said focus on her LFTs, look at her symptoms of dizziness, blurry vision. She has multi-organ involvement, hepatitis, colitis, and probably concern for myasthenia gravis, which you'll have neuro confirm. But the big thing here, the most time-sensitive thing you can do, other than MCS management, is high-dose steroids. Okay. All the other stuff we'll talk about, but essentially that that's why I put that there. Not indiscreetly, just to show that this is really important. So she actually goes to the cath lab for consideration of support because she started having VT, fast VT with dopamine. So, and Ashley was a CCU fellow who called me and gave me a one-liner about it. She had seen a case at UCSF, and she said, "I think this is what it is. I think you're right. I need to start steroids on her." And this is not critical of anything. This is just how the way this field is. This case occurred before all of our registry stuff started getting published about cardiac MRI not being accurate, all these other features of myocarditis. So there's a lot of, at the time, controversy. So I'm in my office. I was actually just curbsided about it. Rushi calls me from the cath lab and says, "You said this woman walked in the emergency room?" I said, "That's what I hear." He says, "The cardiac index on dopamine is 0.74. The mixed venous is 32%. How is this possible?" And you can look at the numbers here. CPO is like 0.14. And my only answer to him was, "I don't know." And then he said, "I'm putting in Impella." And my response was, "Okay, sounds good." Right? So adding on that and lower nitroprusside, and you see some marginal improvement in cardiac index, and she starts to perk up right after a couple days. And you can see her echoes now dropped EF 20% on PA 3.5 liters supportive Impella. However, on hospital day 3, starts to get abdominal distension, lactate starts climbing, starts getting nausea and vomiting because her RV starts to fail. As you know, myocarditis is a diffuse process. Impella only helps the LV, right? So essentially at that point, decision made was to put her on ECMO. And you can see here she was on Edius Impella for dual support. Up until about hospital day 7, they took out the Impella and eventually were able to wean her off. And these are her, post-ECMO hemodynamics afterwards. Never that decompensated. This is like a euvolemic cardiogenic shock patient, which is very fascinating. Did she present in clinical shock the first time around? No. She came in with an arrhythmia. But later, because she wasn't getting the treatments, then she developed cardiogenic shock as sort of a last stage, end stage. And it's a miracle. I don't know how she was able to ambulate into the emergency room. This is someone with an MI who probably would be basically gray and basically dead on the floor, right, if they came in at 911, right? So this is another thing that defies my understanding of why these things happen to patients. However, again, there's a lot of controversy. People were saying this is too far out. It's 5 months out, which now we know is totally possible. So finally, cardiomyopathy did a biopsy showing, as per the PATS report, raging myocarditis, and then CD4-CD8 infiltration of the cardiomyopathy. So some questions I have, obviously, is how can we walk with these hemodynamics? That's my basic question. How the hell are you able to do that? But beyond high-dose steroids, what's the next best immunosuppressive agent, right? And again, giving steroids and whatever you start to do to escalate will treat maybe attenuate inflammation, T-cell infiltration, but it won't reverse the cardiogenic shock. She's already in shock. She's like stage D, verging on E, right? So what's the best strategy for managing cardiogenic shock in ICM myocarditis, inotropes, MCS? We were thankful and working in her favor, she's in remission. So we could literally go full court press for a heart transplant with her, right? But what if someone has active cancer? Well, no one's going to get a heart transplant. Would have ECMO been an option for this patient if they had active cancer? That's a really tough question. And we don't have all the answers to these multiple questions. I don't have a lot of time left, so I'm just going to briefly touch upon again really the amazing game-changing matter of immune checkpoint inhibitor therapies, right? This is a editorial published by Dr. Tony Rivas here, who helped develop Pembro and Keytruda in his lab here at UCLA. Basically, immune checkpoint inhibitors basically allow now the T cells to recognize tumor cells that are able to evade the security systems of the T cell killing systems with this protein, either by two proteins through a co-inhibitory mechanism called programmed cell death, or PD-1 or PDL ligand, or CTLA-4, cytotoxic lymphocyte antigen 4. And with the binding of these signals, usually what happens is the tumor cells are able to bind, and therefore the T cells look at them and go, oh, you're not a threat. I'm going to just go on my way. But once these antibodies block these receptors, effectively the T cells will go, you're a foreign invader, you're a threat, I'm going to attack and kill you. So it's using the patient's own immune system. It's not cytotoxic by itself, right? However, the problem is that PD-L1 expression is seen on a variety of other healthy tissues. That's why we get immune-related adverse events in the gut, liver, and whatnot. And it's also in the heart, and it can also be in atherosclerosis and vascular cells. And in a rare subset of patients, in about 1% of patients, you can get myocarditis. So again, you're like, well, Eric, this is such a rare thing. Why does this matter? Well, because number one, immune checkpoint inhibitors are now approved for over 20 tumors as of my speech today. It's probably going to be outdated by next month. And also, as of 2018, over 40% of the US cancer population is eligible for immune checkpoint inhibitors. So while the incidence is rare, the absolute number, we think, is probably going to go up in this. And maybe, I think it's going to supersede, it's going to be the new giant cell myocarditis in terms of what we're seeing. And how you diagnose this actually can be kind of tricky unless you're coming in like full-blown shock like this, right? And the problem is why it's so important is that up to 50% of fulminant myocarditis are fatal, treatment or not, because we still don't know the right strategy. And troponin is the most, specific sort of biomarker to look for like inflammation, but everything else is non-specific. Something to tell your attendings is that the EF can be normal in 50% of patients with known confirmed myocarditis. And also, if you survive it, your chances of EF recovery is about 50%, and it's about 50% mortality. So it's a rule of 50%, right? And also, rarely does it attack the heart alone. The most common other organs that are involved is always check a total CK myositis. And I've never asked for a neuro exam until I became a cardio-oncologist. So you should always say, I always ask the fellow, is there blurry vision? Or are they complaining about vision changes? And if there is, probably want to get neuro on board. And chances are they've never seen it like this before. But these are all the other systems that you probably need to also evaluate for. However, being rare, you can see here it is certainly potentially the most fatal, with colitis and pneumonitis being the most common manifestations of ICI cardiotoxicities. But if you have something like this, make sure all this other stuff isn't happening as well. But that can also bolster your diagnosis. And time and dose is myocardial immune checkpoint inhibitor myocarditis. And this is from our data from our registry showing that essentially that if you started high dose steroids early on, as well as the sooner you did at the time of the admission, it was associated with a lower MACE event rate. And it just made its way to the ESC guidelines that if you have, a suspected or known ICI myocarditis case, start high dose, no matter what. And then depending on how sick they are, then you may have to escalate their therapies. But beyond that, it's really an unknown frontier. We have no idea what the next best step is. Now, CTLA-4, the target, has been very attractive because its ability to potentially reverse the effect of CTLA-4 agonism, effects of, let's say, ipilimumab. But also at the same time, we have a drug that already does that, and that's abatacept that's used in rheumatoid arthritis. So therefore, the Atrium trial is trying to investigate that, as well as ACLIS is a European trial, also trying to figure out the optimal doses needed to treat this study. And we enrolled our first patient Atrium actually during ACC. And this is literally still a field where it's literally from bench to paper to bedside. This is still one of the things we still do. We read a paper about it, you're saying, oh, there's a checkpoint inhibitor myocarditis case, let's try this, because that's how much we are literally on the forefront of just trying to understand how to treat this. And Rituximab or Jakafi now has gotten some interest in some circles. And now, so if someone comes in now, we try to consult heme to see if they can get this patient on board for this as well, the JAK inhibitor. One of my colleagues, Salim Hayek at University of Michigan, also in his group looked at their cases, and eventually they said that the most sensitive biomarker to look for ICI myocarditis is an elevated CPK or CK as well. But they also saw that essentially that the trends of all these other biomarkers also check liver enzymes, LDH, but the most sensitive in the end was CPK. And again, if you look at the higher that these numbers were, the worse association with bad outcome you have. So the higher they are, the worse they tend to do. And also, something quickly that one of our residents and one of my mentees, Jack Levon, looked at and reviewed in this great paper was that upregulation of potential atherosclerosis potentially can be a long-term side effect of these agents. And we all look at LDL oxidation, all the other pathways of lipid metabolism, but in the end, we think immunology may have a playing role, especially in the cancer population. And we're already seeing signs that essentially that in basic science labs, as well as translational and clinical studies, that some of these checkpoint targets have been shown to actually be, to increase atherosclerotic lesion size, and some actually may even improve it, which I don't have time to go into. But on a clinical level, this has already been demonstrated, or just showing signs of potential upsignals in ASCVD with this study by Tom Neeland, and basically looking at their MGH experience of patients who underwent immune checkpoint inhibitors versus cancer controls who didn't. And they saw a statistically significant, much higher rate of MI, meaning coronary vascularization, and stroke. And they also did a case crossover analysis of the patients who underwent ICI, and they looked at their ACV rates 2 years leading up to using ICIs and afterwards. And they also saw much higher composite cardiovascular outcome of all of these endpoints of myocardial infarction, needing stents, and ischemic stroke. And the third part of their analysis, they actually saw also increase of all the CTs they get of plaque volume. So it's one study, but a lot of us are starting to think that, the long-term cardiotoxicity of immune checkpoint inhibitors is not necessarily the myocarditis, which is certainly exciting, but it might be just good old ASCVD. And then you're going to go back to phenotype 1. How many of them will go back to the original ACS, that these people might be presenting with? And again, this editorial that we have coming out is, again, we don't want all of us, not just cardio-oncologists, to miss the forest for the trees, where the trees are myocarditis, but the forest, frankly, might be a bigger epidemic of ASCVD that we need to be much more aggressive in managing. And we need better surveillance strategies like imaging and biomarkers to study and treat these patients who are living longer. So she got ATG after talking with cardiomyopathy because they wanted big guns given how sick she was, IVIG steroids. Ecmosicamolin day 8, EF 40%, tapered off steroids on GDMT now, New York Heart Class 2, and ICD was placed a couple years later because her EF dropped about 35%. And essentially she's doing well 3 years out. And we're hoping she's past a 5-year cancer-free because at some point we think she probably will need a transplant. So it was a good save, but also a very dramatic story. But again, just showing you the phenotypes of what we need to understand how these people present, because we don't, I've talked with my colleagues, you present either in a bad rhythm or heart failure, and then eventually if you present with both, we're like, essentially you're really screwed. You're really going to be really sick, basically. So no cancer, no recurrent myocarditis. And already, you know, and our interventional colleagues are already trying to phenotype or look at different types of, you know, cardiogenic shock here, right? You know, the non-congested, cardiorenal, cardiometabolic stage. And again, they've already seen symptoms, you know, in terms of, you know, degrees of mortality. These are all, you know, very important things, but also, and also this nice radar plot shows hemodynamic variables that also correlate, you know, with each type of phenotype. And I read this paper with a lot of interest, and I said, man, we should be doing something like this for cardio-oncology because it's such a much more complex, nuanced, heterogeneous population, right? And while these risk modifiers are already used, you know, in looking at risk stratification in patients with cardiac shock, cardio-oncology risk modifiers we need some extra variables like malignancy type, substate, stage, type of treatments, imaging biomarkers, and clinical presentations unique to immune checkpoint inhibitor myocarditis, as I just showed you. So, you know, unfortunately, the studies we need, we are still, you know, we are way behind in this. We don't even have any way of stratifying these patients. We are still in the who gets heart EF drops in anthracyclines, right? But at the time, you know, we really, I think, need to start looking at, you know, methods of severity of staging some of these unique phenotypes, which I hopefully have convinced you that these are things that only happen in the cardio-oncology patients. And then looking at ways that we can tailor treatments or even preventive treatments to prevent these things from happening long term. So in conclusion, cancer patients who develop CS suffer worse outcomes in non-cancer cohorts. And cancer patients have unique phenotypes of CS that warrant classification study mechanisms. And I've just listed 3, and I'm sure there are many more out there that some of the fellows, residents can also have come across and describe. And as new novel agents continue to come out of the market, probably going to see some other strange new cardiotoxic phenotypes. And we really need really well-done registries and randomized clinical trials, which are starting now, are needed to successfully define diagnostic, surveillance, and treatment strategies to improve outcomes in a growing, longer living survivor population. These are, again, all my colleagues, especially, you know, I have to thank especially Marcy and Rushi for, you know, their handling of these really tough cases. And all my colleagues, especially also some of the fellows and future fellows, Orly and Jacqueline, for kind of pointing me in this direction and making me appreciate sort of the unknowns of this space. And obviously our fellows have gone through the Cardio-Oncology Clinic, many of whom have gone on to start programs at their own institutions. Again, I tell everyone, I get my best ideas from the fellows. When people come to me and say, I want to do research, I go, well, what do you want to do? Because chances are, if you have a question about something, we don't have a good answer for it. And we are really lucky to be the backyard of one of the best cancer centers in the country of discovery, and they're all supportive of this effort. And obviously to my colleagues who also help manage this huge network, cancer network as well. It can't be done without this huge collaborative effort. So thank you very much, and happy to take any questions. Is there a question? Yes.
No question.
No, there's not.
Oh, Owen said checkpoint inhibitor myocarditis. Yes, thank you, Owen. I hope you got that. Yes.
You were saying, I couldn't really tell if you were saying that they think the checkpoint inhibitors have some mechanism that leads to increased atherosclerosis, or it's just an overall general inflammatory state.
So there are obviously a lot of this is postulation, but they are seeing that essentially that if you upregulate aspects of T cell activity, including some of the regulatory, you know, aspects of effector molecules, that does, in some sense, has been shown in animal models to cause more deposition and acceleration. On this top note, on this flip side, there is an agent called magrolimab, which was actually written in the was shown in the New England Journal as a sort of a semi-case report. They were using it in 12 lymphoma patients, and they found on their CT PET, their carotid plaque, that the inflammation had decreased. So there are some agents potentially that can actually also attenuate atherosclerosis, and this is something that has generated some interest that we want to work long term as well too. So, but that's another mechanism I think of atherosclerosis that I think that we need to study both clinically and on a basic science level, because we have patients now who are living years on stage 3, stage 4. I see them now. They've been on immunotherapy for like 5 to 10 years. Mm-hmm. Then their stage 4 disease is completely stable. but they do have on their CTs a ton of plaque.
Yeah.
And some of them are not walking around with statins or anything because no one's looked at their CT and their plaque load, basically. So, and I think these are people, when you go into practice, you'll be seeing some of these patients and take the time to look at some of their imaging and make sure that they're appropriately getting treated, not to just say, oh, they have cancer, I don't care about their ASCD health, because a lot of them will probably live many years on, unless, you know, they get an MI or have other heart issues, basically. So,
Well, I mean, it's listed as a risk enhancing factor, just chronic inflammation.
yeah.
I feel like they should be on a statin.
Right, and again, this is a complicated question, right? I mean, it's a difference between stage 4 pancreatic cancer versus someone with, you know, aggressive, you know, or stable stage 3, stage 4 lymphoma. I mean, not sorry, stage 3, stage 4 melanoma, whose disease is rock solid stable, you know, and I think you should have to have that conversation with the oncologist to say, well, things are going well, can we be aggressive? And usually the answer is yes, but they're not usually going to be the ones who are going to pull the trigger on that. You know, usually the cardiologists have to. So, yeah. So. All right, thank you guys. Thanks for staying. Appreciate it.
Thank you.
All right, thank you guys.
I feel like all of these patients should see a preventive cardiologist.
Yeah, they should. Well, that's what I'm saying.